Welcome to Quality. This is your host, Arjun Venkatesh, where we're exploring quality in emergency care. Today's episode is the next in our stroke series. Today, I'm joined not only by Dr. Corey Zackerson from MGH, who co-leads the Emergency Quality Network Stroke Collaborative, but our special guest is Dr. Vasisht Srinivasan, who's an emergency physician, but also a neurointensivist, coming to us from the University of Washington in Seattle. He's an expert on probably all things brain and emergency, but today we're talking about reversal of anticoagulation. Something that when I was a resident was basically as simple as Coumadin and vitamin K, and then there was a lot of debate about that. But now there's a lot of new drugs out there, both for anticoagulation as well as reversal. The evidence is evolving and changing. And Vashi, I got to tell you, it feels like in the last few months, there is a new ACEP Now headline, or there's a new clinical trial that comes out, or there's a new guideline that comes out on reversal. And I'm just getting a little bit dizzy. And so why don't you just kick it off by telling us, what's the one thing that you want to make sure people are gleaning if they're reading all these different things?
Thanks for having me on this. The one thing really is stick to the basics. If there's bleeding, stop the bleeding. This is true no matter in what specialty we're in. Trauma has really popularized stop the bleed, but for ICH especially, if there's active bleeding in the brain, you need to stop it as quickly as possible. There was a study that came out in JAMA Neurology just a couple months ago that looked at the time it takes to get the bleeding stopped and found that getting it anticoagulation reversed within 60 minutes was associated with a decreased mortality. And then, there was a UK group a couple years ago that looked at this, and their timeline was 90 minutes. But they also had BP control and early neurosurgery consultation. And this bundle of care actually helped improved outcomes and 30-day mortality. And again, the key is if there's bleeding, stop the bleeding as quickly as possible. And you can do that in two ways with intracranial hemorrhage. Way one is sort of lower that pressure head, which is why we talk so much about blood pressure control. Kind of joke that neurointensivists are obsessed with blood pressure control, and it's true because we want to know exactly what that pressure head looks like on the brain. If it's too much in the case of ICH or not enough in the case of ischemic stroke, and then also stop the bleeding if it's there. Get coagulation factors in place, get reversal agents in place, whatever it is that you need to do, get that done as quickly as possible. This is really a situation where time is brain.
That's great. The time is brain is something that we've heard over and over in the ischemic stroke world, and it does feel like it's really crossed over into the hemorrhagic stroke space, like completely now as well. And you mentioned a couple of studies, but I wonder if you could give us a little bit more around how should we think about time as brain when we're talking about blood pressure management also, but in particular, we're here to talk about anticoagulation reversal. And so if we're trying to mobilize pharmacy or trying to figure out sort of what do we need to wait for the INR? How do you think about time to reversal?
Yeah, so the sort of the main guideline agencies, AHA, Joint Commission, et cetera, they don't really have great, guidelines or regulatory advice or, check boxes that we have to say, you must get this done in this time like we do for ischemic stroke. Code ICH is starting to become more of a thing, and Neurocritical Care Society, American Heart Association, and the stroke community is sort of pushing that. And anticoagulation reversal is going to be a key part of that. As more and more patients are on these anticoagulants for AFib and VTEs and things like that, it's going to be more important to get that reversal done as quickly as possible. So we don't really have a timeline, so to speak, but again, we know that time is brain. We've known this for about almost 20 years now. Jeff Saver did a paper looking at a large territory MCA stroke and found that you're losing decades of life and thousands and thousands and thousands of miles of myelin and neurons per ischemic stroke. And I think there's a similar analogy in place for hemorrhagic stroke as well, that with that bleed and that brain injury that occurs, you're losing thousands and thousands and thousands of neurons and synaptic connections, and there is significant injury to the brain that is occurring as a result of this. And so the quicker we can get blood pressure under control and anticoagulation reversed, the less kind of an innocent bystander effect we can have and try to limit the damage that already has happened.
Help us with sort of both ends of the spectrum. So on one side, you get the patient to scanner, the radiologist is literally calling you before they're on their way back or they're getting back and saying, oh, they've got a large bleed. You feel that sense of immediacy and you go nuts. The other side of this is our scanners are so good now that we can detect a lot of really small bleeds too. And some of those could be anticoagulation associated. Some of them may be hypertensive. let's assume they're not traumatic for the purposes of this discussion. Is there a line? Like, are there patients that shouldn't get reversed? Or if we've got atraumatic blood in the brain, should we just reverse everyone?
Yeah, that's a good question. I think there's some sort of reasonable steps that we can take. I mean, if we know that for sure that the family or the patient said, oh yeah, I haven't taken my warfarin in 4 days and the INR is 1, you probably don't need to reverse that person. Or, the last time this person was seen normal was 4 days ago and there's no DOAC pills anywhere, and or they have a brand new packet of their apixaban and none of the pills have been removed. Okay, well, they probably are not anticoagulated. But I really think unless there is a very clear data point that says these people are not anticoagulated, the risk-benefit ratio generally does fall toward the reversal of anticoagulation. If there's any suspicion that this person is on a blood thinner, we should try to stop that bleeding from happening.
And you don't think size matters. So because it could just be like where they are in the course of illness, but if it looks small, does that mean don't reverse or absolutely do reverse because it could become big?
You're right. We don't know where in that timeline they are. There are some CT findings and CTA findings that tell us that this is a bleed in progress, or maybe this is an older bleed. I think if you have evidence that this is an older bleed that has already established, and patient was last seen normal a week ago, and there's already CT changes that suggest that this is an older bleed, you could maybe have that conversation. But I think any kind of fresh blood, hyperdense findings on CT scan, you should just err on the side that this is a bleed that's in progress and go ahead and reverse. Because you don't know if you are catching it at the early point where the bleeding is starting, or if the bleeding's already ended and the clot has formed and it's not going to bleed any further. And you won't know that until you get your repeat scan. And by then it could be too late.
You're making the decision really clinically. You're not waiting for labs to come back. You're just looking at the patient in front of you and what you know, and knowing that sort of time is brain and moving forward. Do you have advice on how to think about improving our processes in the ED when we're doing this? Because, I know that every ED has its own issues and idiosyncrasies, but in ours, for example, we have pharmacy right there. I know there are places where there's not pharmacy, or, there are so many different ways that barriers are going to come up in moving this forward. And so do you have some sort of general advice for how to do this quickly and well?
Yeah, so I think it is impossible to know a priori whether somebody has an ischemic stroke or a hemorrhagic stroke. There are some guesses that we can make one way or another, but in general, we're really, really bad at determining that. So I think institutional protocols that exist for code stroke activation and procedures like that should be enacted as quickly as possible, because then that will allow patients to get, as soon as they hit the door of your ED, get back to the scanner as quickly as possible and get that information. Because if you have an ischemic stroke, you go down that pathway. If you have a hemorrhagic stroke, you go down that pathway. And so that's really the first decision point. Get that imaging quickly. Once you've identified this is a hemorrhagic stroke, big basal ganglia hemorrhage, what have you, then you start getting down the line of, okay, well, airway management. Do they need their airway protected? Are they doing okay? Control their blood pressure, reverse anticoagulation, and then get them to a facility that has neurosurgery and stroke neurology so that they can have those types of conversations and, MIS and clot evacuation and all that stuff that's actively being researched now. In terms of what you can do locally, I think partnering with your pharmacy and your nurse leadership is paramount here. Even if you don't have an ED pharmacist, you will still have inpatient pharmacy, or a pharmacist affiliated with that hospital, and that those individuals, especially those in leadership roles, can work with you in the emergency department to create these protocols so that when you have a hemorrhagic stroke patient come in, that you get certain people activated, you get certain protocols in place so that you get meds faster, you get, work with your lab directors even, so that can we maybe prioritize that in these specific patients, can we get the INR back faster, or an anti-10A level faster, or, a certain set of coag profiles faster. And so I think working with your lab folks, with your pharmacy folks, and with your nursing folks to say like, hey, this is not a person that should be put in sort of that back corner of your emergency department. This person, at least initially, needs to be in a big resuscitation bay and needs access to airway equipment, needs access to close monitoring. And, these are critically ill, technically ICU patients. And until you can demonstrate stability and that you've done all your reversal and that, you've done sort of all the things that you need to do, you really shouldn't walk away from this person.
All right, let's play a game of alphabet soup. In the world of reversal, you've got PCC, you've got FFP. I've even seen protocols where people take cryo and write it in 4 capital letters as if it's like another acronym for something else. And so, there's a lot of good data now that basically shows that we have fairly widespread adoption of DOACs. And so, and what sort of remains as use of warfarin seems to be increasingly special scenarios or people who've really been on it for a long time and just sort of are not switching, but that you've had pretty rapid change over the last 4 or 5 years.
Yeah.
Knowing that those are the patients we largely are seeing in the ED, and you see these DOACs, patient with DOAC and atraumatic bleed, how should we be thinking about these different treatments, drugs, and the prioritization of them? So what do I need to make sure happens in my ED? A lot of our EDs in equal or rural or community-based. What do they need to absolutely be transferred for? But how do you sort of sort through that initial stage of care?
Yeah, so when you're thinking about anticoagulation reversal, it's important to figure out what agent these folks are on. And you're right, most people now are on a DOAC of some sort. There's still a handful of people wandering around that are on low molecular weight heparins and dabigatran and things like that. And there's still people walking around with warfarin because that is really the only approved agent for a lot of things still. And so I think identifying the agent is the first priority. And if it turns out this is warfarin, great. We have an established, time-tested protocol for how to reverse that. Get that vitamin K on board, get FFP, PCC, whatever you need to do. If you have a DOAC, that's where things get a little bit more interesting. The paper that everyone's sort of talking about right now that was just published about a month and a half ago in the New England Journal was the Connolly et al. Paper that was the Anexa-I paper that just came out that looked at essentially 4-factor PCC versus andexanet alpha. And, there's the headline that's being reported, and then there's the details, as there always is in every study. And so I think without kind of diving into the weeds of that, the headline is basically that the trial showed that andexanet had better rates of stopping bleeding and lower hematoma volumes compared to PCC, but did not translate to better functional outcomes. And there's some other intricacies within the study that, need to be considered. So I would encourage everyone to actually read the paper and look at the details and look at the results and see if that's something that they agree with. A lot of EDs are starting to bring this on board now. And I think if it's on formulary, this is a valid approved agent for the use of DOAC reversal and should be used. There is that caveat of an potentially increased thrombotic risk that needs to be talked about with any reversal agent, but andexanet alpha for sure. If you don't have andexanet alpha and you have 4-factor PCC or whatever flavor of PCC, we know that works reasonably well, and that's in the Neurocritical Care Society guidelines as well as many other national guidelines. Using that is very, very adequate. That's what we use at my shop, and we used it a lot of other places where I've trained. And so I think use what you have. If you have nothing, obviously that person needs to be transferred. If all you have is FFP, it's better than nothing. If all you have is PCC, better than nothing. But if you have specific targeted agents like, Praxbind or idarucizumab or andexanet alpha or, what have you, use the targeted agents if you have them available.
Can I ask you to nerd out on those results with me for just a second? Because I think the thing that I struggle with is, we talk about the SABRE paper from back in the day, and that we know that with every minute is, X number of neurons and, these like disability adjusted life years lost and all this stuff. And then we see results where the hematoma is contained or the volume's lower. We have sort of biological or physiological endpoints that look good, and yet they don't translate to actually patient-centered outcomes. So I guess the thing, and I haven't read that study in detail, so maybe the answer's in the numbers, but I guess I'd love your thoughts on like, why do you think that is? Are they not powered to find differences in patient-centered outcomes? Is it something else going on?
Yeah, so I've read about this paper. I've read this paper a couple times now. I've talked a lot about this. I had a little tweet blast on social media. I don't know if you're supposed to call it Twitter anymore or whatever it is now, but I think it's an important paper to I think really read and understand. So nerding out on it a little bit more, these are patients that were taking a factor 10A inhibitor, so some sort of DOAC, last dose taken within 15 hours since randomization. And then this is where it gets a little tricky, is that they ended up changing the protocol a couple of times during the study and adapting it so that they initially included people with subdurals, and then they changed it midway to only have spontaneous ICH. Their hematoma volumes were less than 60 mLs. They initially had a time window that was a little broader, and then they narrowed it down a little bit more. So there are some protocol issues that I think raise some questions about what was going on here. The efficacy analysis was done as an intention to treat analysis. The safety analysis was done in all patients. And the follow-up time window was 30 days. So, and it's a little odd that they chose to pick 30 days. Most every single other ICH trial uses 90 days as their standard follow-up metric. So was it a funding issue? Was it a timeline? I'm not sure why they picked that. That was just another thing that made me go, that's interesting. And then obviously, anytime a trial ends early, you want to ask the question of, well, had you continued it on to get your full numbers, would you have seen a different result? And there is potential bias. We don't know what the fragility of the trial was by ending it early. I think that's sort of another X factor there. And then when you look at the actual primary outcome that they looked at in this study, there were 3 parts to it. Part 1 was a change in hematoma volume. And so they defined excellent efficacy as 20% or less increased volume, and good efficacy as 35% or less. So that was sort of part A. Part B was an NIH stroke scale increase less than 7 points at 12 hours. And then part C was no rescue therapies were administered within 3 to 12 hours after randomization. And so the composite outcome was statistically significant, favoring andexanet. But when you break it down into those 3 subcomponents, the only thing that it actually was significant was the change in hematoma volume. And we've known this for a long time. We know that andexanet alpha as a drug is really, really good at stopping bleeding and preventing the clot from increasing in size. We knew this from ANEXA-4. It's replicated here in ANEXA-I. But the patient-centered outcomes and the patient-centered portions of it, meaning they didn't need further rescue therapy, their NIH stroke scale increase wasn't significant, those were not statistically significant between the two. And so, you got to ask the question of, it's really, really good at restricting the size of the clot and preventing hematoma expansion, but that doesn't translate into better outcomes for patients. And so that dichotomy there is super interesting and makes me wonder, what is it that we're missing here? Is it that the hematoma volume, because the hematoma volume really does matter. We know this. The initial trials for the ICH score, correlate hematoma volume with eventual outcomes. And while we shouldn't be using the ICH score to prognosticate in the emergency department, it is a tool that our neurologists and neurointensivists use to help sort of at least put people into buckets of, this is really, really bad, or this is okay, it's not great, but they can recover from this. And so when you have this dichotomy, it's hard to know why the hematoma volume decrease doesn't translate into better functional outcomes, both in exam change and on the modified Rankin score at 30 days. And again, had they extended it out to 90 days, would we have seen a difference? No way to know that.
Yeah. So
Yeah, I mean, this is the tension between quality improvement and clinical research. And so I'll play it out a different way, which is sometimes I feel like we get stuck in sort of the world of knowledge translation, evidence-based medicine, which is that our clinical trials need to be so perfectly designed because of either resource limitations, right? There wasn't enough money to do a bigger trial, or the disease itself is hard to go enroll everybody. This is something where, we know even from our equal data, it is the minority of the ICH patients, actually. It's not the majority of ICH patients that our equal EDs are seeing that have anticoagulation at all. So most people that have an ICH are not anticoagulated. Yes, many are. When many are, then they have to be on the right drug to be enrolled in the study. Then they have to meet a million different criteria to be enrolled in the study, and they happen to have to be at one of the EDs that's an enrolling site for the study as well. That's really, really hard. And sometimes I wonder then if all the things that get done in order to pull off a trial, we then over criticize the sort of narrowness of the population and then interpret sort of the surrogate endpoint. Okay, well, the hematoma didn't get bigger or smaller as well. Well, it didn't really change the outcome. And so we don't change care. The alternative approach, if you sort of thought about this the way we think of a lot of QI stuff, would be to say, okay, we have in a select population a trial that was stopped early. It had improvement in this one outcome. It's not necessarily the most important outcome, but it's directionally the way we wanted it to go. And we should, if we're a learning healthcare system, adopt this into practice, but be open to the fact that if we find harm, we'll stop it or we'll switch to something else. And so how do you wrestle with that? Because I think that's where I get stuck, especially in this disease state, more than anything else.
Yeah, and it's we can really dive down into the nitty-gritty of any study, really. I don't want to pick on this particular one in terms of that what is it powered for, what were your primary endpoints, second, you can really sort of delve into this, argue about the differences between non-inferiority studies and superiority studies and all of that. But ultimately, the question that I think we all want to know as clinicians is this actually going to help the patient in front of me? And I think from the 50,000-foot view, this drug actually does seem to work, and it does seem to do its job. And so if it's available, we should use it. Am I kind of knocking down the fortress and saying we must have this in every ED on the planet? Absolutely not. That's a marketing thing. That's a sales issue. That's nothing to do with me. But I think if the drug is available, and if you have a choice between andexanet or PCC, this trial, at least to me, tells me that it's a wash and I should use something. Whatever's readily available, it's going to work just fine for the patient in front of me.
So yeah, I think the sort of last question I have related to that is, if you're saying you're not, sort of knocking down the door or drawing these huge distinctions between PCC and andexanet alpha, then when do I transfer the patient and when do I not? Like, when do I say this patient needs the reversal and I'm going to transfer them because I don't have it, versus actually I can just give this thing that I have and that's going to be okay?
Yeah, and I think again, based on this one individual study, I think you could make the argument that andexanet is the agent that we should be using, and if you don't have it, you should transfer the patient to receive that antidote. But I think the data also tell us from this and other studies that PCC works just fine. We've had a long experience of it working really well in our patient population. And so if you have it, you've essentially given the antidote. It is part of the Neurocritical Care Society guidelines, AHA's guidelines. And so you're giving an antidote that does work. And in my mind, the transfer question really comes into what else is going on with the patient. If it's a very small basal ganglia bleed that you're controlled, the patient is neurologically normal, it's a deep bleed, talk to your surgeons, talk to your stroke neurologists. They don't feel like an operation is going to be helpful or needed. If your facility can handle that patient, I think keeping them there is probably the best course of action. If it's a larger bleed, or if there's, a potential that a MIS procedure can do some clot evacuation and maybe have some benefit, we're starting to see more trials on that come out now. And that may end up being the future of ICH care as the technology gets better and better. That may drive the transfer question more than anything else.
Good point. Just like we're not making single drug decisions often in the care of patients, we're not making single item decisions in transfer. Yes, there's a leading reason often for why we transfer care, or why a patient gets even admitted to a hospital, but it's really a mosaic of what that patient's needs are, and sort of what they need next. That's really
Correct. And then on the flip side of things, a devastatingly large hemorrhage in a patient with a very poor exam that sort of everyone looking at the scan of this patient have decided this patient is not going to survive. There's no chance for meaningful neurologic recovery. It's even in that situation, it's a toss-up. There are a lot of people who would say, why are we torturing this patient by transferring them, and we're, causing harm to the family. They now have to go 6 hours away to some other facility, and the patient's going to die there instead of dying close to home. On the flip side, a lot of these facilities have the end-of-life care and the palliative care and things like that can help that transition be a little bit more comfortable and easier for patients and their families that smaller facilities may not have. So I think it's really understanding your local health system, your referral partners, and what they are able to offer and not offer.
That's a great summary. Yeah. Thank you, Vashi. This was wonderful. This was a great conversation. I feel like I'm smarter. I know a little bit more about the evidence. I know a little bit more about the newest evidence in this space. And I know our listeners out there will truly appreciate this when they're trying to take care of these really sick patients in our EDs. Hope to have you back in the future. Thanks.
Yeah, thanks so much. Happy to come back.